Great, thank you, Maddie. Now we'll transition to the presentation portion of the session. I'm pleased to introduce Dr. Traber Giardina. She is a patient safety researcher at the Houston VA Center for Innovations in Quality, Effectiveness, and Safety, IQuESt, and assistant professor at Baylor College of Medicine. Her research is focused on better understanding patients and family experiences of safety events, primarily diagnostic errors. Dr. Giardina was recently awarded an AHRQ K01 Career Development Award to develop patient-centered diagnostic error reporting systems. Welcome, Dr. Giardina, and thank you for presenting today. We'll turn the presentation over to you at this point.
Okay, great. Okay. Thanks for having me. I'm always happy to talk about my research. The paper I'm going to talk about was recently published in Health Affairs. And just to give you a little bit more of my background, I'm a qualitative researcher, and I'm also a social worker. I'm going to go ahead and get started. There we go. So just to give you a little bit of background, definitely don't want to preach to the choir, but as most of you know, diagnostic errors pose a significant risk to patients, and they impact as many as 1 in 20 U.S. adults annually. Currently, there's no single detection approach that has sort of been identified as the gold standard or the best method to identify diagnostic errors. So unfortunately, these types of errors are generally underreported. So most of the reporting systems only capture a fraction of the errors that are actually occurring. There are a number of reasons for this. Clinicians often don't report. Sometimes they don't know a diagnostic error occurred, or they don't have time to stop and report. And perhaps some clinicians don't see the value in reporting, especially if they're not receiving feedback. So these errors are also often missing. Diagnostic errors are often missing from the medical records, and they're not gathered through incident reporting. So unfortunately, we don't have necessarily a lot of information about them. So the patient's experiences in particular are missing because there may not be an avenue for patients to report, or they may not know about them. And therefore, causes of those types of errors are often hidden. So historically, patient safety literature, diagnostic error research in particular, have generally focused on clinicians, how they think and how they act, and then how to design systems to meet those needs and avoid errors. So this focus has largely left patients out of the research, and we sort of have failed to recognize the value of patients and families' perspectives and their needs and their feedback for diagnostic error literature in general and understanding how they occur. So focusing specifically on patients' experiences, patient reports of their experiences of diagnostic error can provide valuable information about those errors. And as I mentioned, they're often absent from the sort of traditional measurement mechanisms. So unsurprisingly, patient complaints of clinician behaviors, especially negative attitudes and behaviors towards patients as they relate to patient safety, are underexplored. And beyond that, patient complaints are often sort of looked at as satisfaction issues rather than the significant reports of behaviors that may actually be contributing to the safety events they've experienced. So in 2015, Dr. Southwick and his colleagues published a paper in BMJ Quality and Safety focused on patients' voluntary report of adverse medical events. We saw that paper, thought it was very interesting. And as you can see, when they broke down the types of adverse events that patients were experiencing, diagnosis, failure of diagnosis or treatment was the largest group. So we were interested in sort of digging into that data because they also collected patient stories and sort of looking at specifically diagnostic error to see how patients are talking about them. So the purpose of our study was really to explore patients' diagnostic error experiences to gain a better understanding of the behavioral and interpersonal issues that patients and families identify as contributing to those errors. So we conducted a qualitative analysis of written narratives. So to identify our cohort, we first pulled all the survey responses that were submitted to the Empowered Patient Coalition between January 2010 and February 2016. So let me back up a little. Patients, even today, are able to go to the Empowered Patient Coalition website and report an adverse event. The survey is still open. So we collected data from those years, 2010 to 2016, to look specifically at diagnostic errors. So we identified all the self-reported diagnostic errors that also included a written narrative. So the patient first had to say that they experienced a diagnostic error through structured data collection, and then also include a written narrative. So at the end of the survey, every respondent is able to write in a story of what happened if they so choose. To be included as a diagnostic error, the participants had to have selected a delay in a diagnosis or treatment, a misdiagnosis, proper test not ordered, test lost, misplaced, or disregarded. The last category is laboratory or pathology error. And those are included right here in our little flow chart. So there are 465 total with a reported diagnostic error and the narrative. From there, 2 of the authors reviewed all 465 narratives. At this point, to be included, the narrative written had to include a diagnostic error. So we used the National Academy's definition to decide whether or not a diagnostic error was included in the narrative. And just to refresh, that definition is the failure to establish an accurate and timely explanation of a patient's health problems or communicate that explanation to the patient. And so from there, we had 184 who met the inclusion criteria. I do want to point out that these 281, they did report a diagnostic error. They just didn't discuss it in their narrative. That doesn't mean a diagnostic error didn't occur in this set. It just means that in their narrative, they didn't discuss it. Many of the folks who reported adverse events experienced multiple types of errors. So in their narrative, they may have talked about the one that was most significant to them or the one that was more vivid in their memory, as opposed to talking specifically about the diagnostic error. So as far as the analysis, we did conduct a secondary analysis, and we used thematic analysis to identify patterns and themes across a very disparate sample of diagnostic error stories. So moving to the results. I included a table from the paper. So as I mentioned, we had 184 narratives that met the inclusion criteria. So we analyzed all 184. There was a pretty even split between patient self-reports and a family member reporting an error. The sample consisted of majority female patients, and the average age was 52.4 years old. Most of the reported diagnostic errors took place in the hospital setting, and all of our respondents, as I mentioned before, experienced more than one type of error. So they may have experienced multiple errors. Almost 3/4 of the narratives included a discussion of problematic clinician behavior. We defined that as behaviors not consistent with patient-centered care. And these behaviors were associated with as part of the diagnostic process. So some of the 4 major themes that we identified were ignoring patient knowledge, disrespecting patients, failure to communicate, and the last category is manipulation or deception. So I'll go through all the themes and sort of talk a little bit about each example. So the first is ignoring patient knowledge. This was the most salient theme. We saw this sort of across the narrative. families families and patients reported feeling like they were being ignored or dismissed by clinicians, despite giving them evidence, such as concerning symptoms, a change in status, or failure to improve. And this theme really focuses on information transfer from the patients or family to the clinicians. So while their experiences were very diverse with different types of diagnostic errors, many of the participants talked about being ignored. And the words they used were things like dismissed, ignored, would not listen, did not pay attention, and did not take seriously. And in this patient case, the patient had sepsis. While the surgeon did originally acknowledge the patient's status had changed, he was dismissive of the family member's level of concern for the patient, and this resulted in a misdiagnosis. And the family member, unfortunately, she watched her husband deteriorate over 3 days following a colon resection. So she experienced a lot of emotional issues watching her partner deteriorate over time and feeling as if the doctor wasn't listening to her concerns about his change in status. The next category is disrespecting patients. This theme focuses really on the manner in which a clinician communicates with patients and families that leads or contributes to a diagnostic error. Participants indicated several types of disrespectful behavior. These were things like feeling like they were being belittled or mocked, or just simply the clinician was behaving rudely towards the patient. A number of the reports centered on patients who considered the language that was being used to be insensitive or impolite. Another sort of theme we found within this one is stereotyping patients. So patients sort of felt like they were being labeled as drug seekers or having mental health issues rather than the symptoms being attributed to something physical. So in this case, this patient, she had been to the ER multiple times with abdominal pain. And in this case, this particular visit, the clinician did not put the stethoscope in his ears, but acted as though he was listening to her heart and told her she was fine, and she left. She was misdiagnosed for over 3 years, and she had advanced metastatic colorectal cancer. The next category is failure to communicate. So this theme really focuses on information transfer from the clinician to the patient. So this ranged from ineffective communication styles to clinicians outright refusing to speak with patients and families, or not speaking directly with the patient and family. So in this case, this patient was hospitalized. In this case, she had surgery. She had a hysterectomy, and she was having ongoing issues and pain. She called her surgeon a number of times, and the surgeon was not responsive. She was later hospitalized, and her ureter had been cauterized during surgery, and this had gone undiagnosed for a week while she was calling multiple times to get help. So the last category, manipulation or deception. This theme was the least salient, but we felt like it was important to include it because while it was less salient, patients were talking about this occurring, and it had a significant impact on them. So this includes using fear to influence a patient or family member's decision, or misleading or misinforming patients. In this case, this patient, her cardiologist had felt that she needed to go have some additional tests done. And when she went to the hospital, the radiologist did not agree and believed that she had an ascending aortal tear and no further testing was needed, and thought that she should undergo surgery immediately. The patient wanted to get a second opinion. She didn't feel comfortable. She felt that her cardiologist had recommended more testing. And unfortunately, she felt sort of backed into a corner to have the surgery. There was no aortal tear. And after the surgery, the surgeon came in and told her that she was lucky that she didn't have a torn aorta. For this patient in particular, using fear to influence her decision resulted in significant emotional, physical, and financial consequences. So moving on to the discussion, our review of patient and family reported diagnostic error experiences identified clinician behavior and interpersonal factors that they thought contributed to their diagnostic error. Patients connected the behaviors to the diagnostic error. And these behaviors caused participants in the survey to experience feelings of guilt, fear, and loss of trust in their clinician. So despite increased awareness about the value of patient reporting, there are no current policy or practice initiatives to supplement the existing patient safety data using patient-reported experiences or their information or their feedback. This valuable data is not currently being captured necessarily through any mechanism. And though healthcare systems are increasingly collecting patient complaints, this data may not be the best method to identify diagnostic errors because there are so many issues that patients can experience anytime they interface or interact with the healthcare system that diagnostic error could easily be lost in all of that data. So it's not surprising that we have very little data on these types of behavior towards patients. However, we do know that these types of behaviors that patients talked about, they do have a negative impact on diagnostic and procedural performance, and they can be harmful to task performance and teamwork. These types of behaviors that we've talked about have been well documented in the literature among clinicians, and a recent study of trainees found that they reported unprofessional behaviors related to safety. And in this study, the Martinez study, they define this behavior as covering up errors, falsifying documents, or insulting others. Trainees indicated that they witnessed these types of behaviors more frequently than traditional patient safety breaches, which is things like hand-washing behaviors. So unfortunately, these behaviors in particular are less studied when they're directed towards patients. So it's imperative that healthcare systems proactively begin identifying harmful behaviors and address these behaviors that can harm patients. A good start is working towards creating a culture that prioritizes safe diagnosis. This may mean facilitating and encouraging patients and clinicians to report these types of behaviors, making sure that it's clear patients know where to go to report them and who they need to talk to. Also investigating and intervening on these behaviors so that if multiple clinicians are having multiple reports, that action is actually taken to address them. And then also providing timely feedback to those who report. It's hard for folks to see value in reporting if they're not receiving information back, knowing that issues are being addressed. Another way that we suggest to address these behaviors is by adding requirements for ongoing and lifelong communication training that helps clinicians respectfully elicit and respond to patients' input within the context of the diagnostic process. Some of the strategies could include training on managing patients' expectations. That might include focusing on building or things that damage rapport, and also focusing on the importance of having shared expectations for patient safety. It could also include adding content to the recertification process that's specifically focused on communication skills, professionalism, and how that relates directly to patient safety. So just to wrap it up, in our study, we found that patients and families' experiences of diagnostic errors are a valuable and rich source of information about diagnostic errors and what might be contributing to them. And we found in particular that patients and families identified unprofessional behaviors as factors that do contribute to diagnostic error. And finally, healthcare systems should be formally collecting patients' experience those diagnostic errors. So I just quickly wanted to thank my co-authors and Mothers Against Medical Error and Empowered Patient Coalition, and also the patients and families and caregivers that reported their experiences, and listed the funding agencies and my contact info if anyone wants to reach out directly.
Great. Thank you so much, Dr. Giardina. One quick question, I'm going to open it up to the floor, but that I just had and maybe others had is the Empowered Patient Coalition, do they take narratives from patients across the country, or is that something specifically that's done within the Texas health systems?
Oh, sorry, I should have clarified. It is a website open to anyone, anywhere, as long as you can get to the internet and plug in the address. You can find the survey. It's open,
okay,
nationally, internationally.
Thank you. Okay, we can. The floor is open for any questions or comments.
This is John Ely. Can you hear me?
Yes, we can hear you.
I'm a family physician in Iowa, and I had a couple of comments, I guess. One is, it seems like it would be ideal if patients were not the ones that had to, or at least not the only ones that would report errors, diagnostic errors, and that there should be a system like airline pilots have of reporting errors. And probably we need both patients and physicians to do the reporting. The traditional, and there are lots of reasons why physicians don't, one of which is malpractice fears. Another is being worried about hindsight bias, and is it just my hindsight that makes me brilliant, or was there really a error looking prospectively? But I think, and part of it is culture, which is related to the malpractice issue, but also related to sort of the image of the confident physician needing to be confident in order to reassure patients that they know what they're doing. So this all kind of gets mixed up together, and I think is a barrier to reporting by physicians. The other barrier, I think, is the fear of overdiagnosis, or engaging in overdiagnosis. So if I take every patient seriously, including patients who are worried that they have cancer but don't, but they're still worried, I can continue to pursue that. But if we do that with everybody, then we're going to have an overdiagnosis problem, which we already have. And sometimes it's an impossible tightrope to walk. Impossible to walk, to take the correct path given the unpredictability of human biology. So those are my comments. The other thing that interested me was you mentioned some things that build rapport and damage rapport. And I'd be interested if you could expand on that, like specifically what things build rapport and what things damage rapport, and maybe what builds rapport without overdiagnosis. So anyway, I'll stop and let you respond.
So unfortunately, I'm not an expert in communication, but I think it is possible to, and there is literature on those relationships and power dynamics and things like that, as far as building rapport with patients. So I think it's possible to design those. I apologize, I unfortunately don't have suggestions for that right now. But that's something that we can, look into moving forward as far as trying to create educational programs that might be helpful to help foster that physician or clinician-patient relationship. And as far as overdiagnosis, I recognize that can be an issue, but going through the stories, you sort of see, so a lot of the patients were hospitalized, and they're sort of watching folks, their family members deteriorate. So in these specific situations, they're a little different. And again, most of our sample, I want to say almost 80%, is hospitalized patients. But that is something that, we have to think about in my research in particular.
So just to respond to that, I think the stories that you presented are, and the stories we hear at the DEM meeting are selected. And in order to, highly selected, and in order to really understand why this happens, I think it would help to have a more random sample or a balanced sample. So what you need is stories that are exactly the same, except that the patient doesn't have cancer that was missed, or the rude, arrogant doctor made the right diagnosis, even though he or she was rude and arrogant. And we don't ever hear about those, but they exist. And I think in order to really understand this problem, we're going to need to look at both sides of the coin. And so far, it seems like we were only looking at one side of the coin. So I'll stop there.
I have a question and a comment. My name is Dan Merrick. I'm a misdiagnosed patient who luckily survived in 2015. And I've done quite a bit of research to understand what is the problem and what are the problems in the diagnostic process. I've been working also with Dr. Graber, with people at Brigham and so on. So, I think you were touching before on how to communicate diagnostic uncertainty. And I'm an engineer. I'm a business. I have a business degree and engineering degree, and I look at it more from a process perspective. And communicating diagnostic uncertainty is certainly an issue, and it's a delicate balance for the physician. And but I think that what I think doesn't happen today is in each facility, in each hospital entity, to really have a collection of the good and the bad as well, to be able to analyze. And I would like to somehow draw the parallel with the Six Sigma process that Toyota used in the 60s and 70s to improve the very crappy process to become the most reliable car in the world and the most popular car in the world. And what do we do? Because if we don't measure this diagnostic errors, and I saw that you also mentioned that they're very underreported for fear of malpractice, for fear of image, and so on and so on. But how can we change the image of reporting a diagnostic error to twist it into something constructive? Hey, we have a diagnostic error. There's several ones. There are good things. How can we change something in the process? And I'm not going to continue to. There's a great example in Germany, which has a grossly underreported diagnostic error situation. But there was one example when a doctor administered administered intravenous a antibiotic that was supposed to be delivered orally, and after this they changed the syringe to have head that's square instead of round. But that's a very simple example where you change the process to avoid errors. But how can we also change that behavior from something punitive like malpractice and loss of image or so and so on to something positive? Hey, we're collecting these errors to do an analysis and improve our processes or improve something in communication and training to work together, patients and doctors and the hospitals, to have some sort of an impactful change. Because I see so many studies, so many papers published, but what are we doing concretely in making a change?
Hi, this is Dave Newman-Toker. By the way, thank you, Dan, for joining us. We appreciate it. A couple of quick comments and then a question for Dr. Giardina. Obviously, sampling frames are really important, just in response to John's comment about the fact that, you know, we're only seeing the numerator and not the denominator here. Obviously, it's the case that we need to have measures and things that give us both the numerator and the denominator, but that doesn't mean that you can't learn things from incident reporting and numerator-only cases. There are insights to be gleaned there, and I think Dr. Giardina has very nicely pointed some of those out to us. Just one quick comment on the overdiagnosis issue. I think we should just be careful, since this is a research forum, that we're at least aware of how that term is used in the general patient safety literature, which is not exactly the way that you used it, John. I think what you were referring to was sort of over-testing. Overdiagnosis has this sort of specific epidemiologic meaning that you're finding diseases that didn't need to be found, but you're correctly identifying them, as opposed to just doing too many tests looking for diseases the patient doesn't have. The question for Dr. Giardina is, going back to the manipulative and deceptive group that you mentioned, which of course sounds particularly pernicious relative to some of the other failures in patient communication. Not that disrespecting patients or ignoring patient knowledge are all that much better, but could you clarify the example that you gave and maybe give one or two other examples of that small category? Because the one that you gave, where you said you used scare tactics and told me I'd die any minute, at least for me, I interpreted that a little differently. I interpreted that as somebody who made the wrong diagnosis and was a little too sure of him or herself, presumably himself, and then he was acting on that misdiagnosis rather than necessarily understanding, you know, deep down that the patient probably didn't have an aortic dissection, and he was just trying to scare her into doing a procedure that he wanted to do. Could you explain, was there more context for that, or was it a judgment call about how you classified things in that category? Can you give us one or two other examples?
Sure. So I think it's important. So as I'm analyzing it, I'm always looking from the patient's perspective and the way that they're talking about it. So I realize that that language might be a little evocative, and maybe even in that example, the clinician's intention wasn't to use fear to influence the patient. Maybe you're right, maybe that the surgeon and the radiologist in that example felt like she was going to die if she didn't have it. But I think from the patient's perspective, they felt like, and they also have hindsight, right? Like, she knows that she didn't have the aortal tear, but she felt like in that moment, she was being pressured into making a decision, and her options, such as, you know, getting a second opinion, were being overlooked because they were pressuring her to have the surgery. So I think from her perspective, she felt like, and again, this is a narrative that was written, but as analyzing it from her perspective, she sort of talked about it as being backed into a corner to make a decision without any options being given.
So that makes sense to me from the perspective of sort of just thinking about it purely from the patient's perspective. But I guess then that gets us back to the question that John asked earlier. So I'll give you a personal example of a case where I did that to a patient, where I essentially deliberately manipulated them psychologically to get them to pay attention to their illness. So there was a patient, she called up on a Sunday afternoon. She was a nurse. She was thought that she had just needed to decrease her medication dose because she had some side effects, and it turned out it was my wife's patient, and the symptoms were dizziness and double vision, and so she put me on the phone, and essentially I had to convince the patient that she was at serious risk of having a vertebral artery dissection and a transient ischemic attack and a stroke. And after I'd taken some history, I was very worried about this. But in order to convince her, to motivate her to go to the emergency department, I essentially had to, read her the riot act list of things that could happen to her if she didn't, like ending up locked in, as one of our patients that we work with today did end up when his vertebral artery dissection was missed. So kind of getting back to the question of how we think about this from the physician's perspective, at least in that case where it turns out that I was right and she was wrong, it wasn't just a medication side effect, and it was a vertebral artery dissection, and thankfully she got the diagnosis, thankfully she got the treatment, and thankfully she didn't have a bigger stroke. We can look back with hindsight and say, maybe we're glad that I twisted her arm a little bit over the phone to get her to go to the emergency department. In fact, I actually had to get her to go to 2 emergency departments because they ignored her at the first one. So I really had to kind of work hard to get her into the system and appropriately diagnosed and treated. The question is that an appropriate thing for physicians to do, to try to get patients the right diagnosis or right treatment? Obviously slightly different than railroading somebody into a therapeutic procedure like a sternotomy to deal with an aortic dissection that's not there. But there are these very time-sensitive situations, and so if you make the wrong diagnosis and over pursue it, in service of the patient, that may be an issue. I'm just curious sort of what you and maybe others think about this issue on the call of kind of, is that something that we want to view as uniformly ill-advised, to leverage one's knowledge of the situation and the risks associated with it to help convince the patient of something that you think is very serious and in the patient's best interest?
Can I step in? This is Helene Epstein. Dr. Newman-Toker, I think that your story was fascinating, but I doubt that the patient whose life you saved would report that as a diagnostic error. She might actually be telling everybody about how you were invested in saving her life. The patients who are reporting diagnostic errors are people who either were overtreated or undertreated or received the wrong treatments, and perhaps on top of that, because they were disagreeing or in some way of not applying exactly with the instructions that they were being given, were treated roughly or dismissed or ignored or pressured. So your patient that you just told the story about would never be in this group of people reporting.
Sure, I know, Helene, but I mean, also, if I'd been wrong, which I could have been wrong, right? Like the fact that I was right, I'm glad for her that I was right, and I do my best to be right as often as I can be, but we're all wrong sometimes. And so the question is, had I been wrong, had she not had a vertebral artery dissection, had I put her through 2 emergency room visits, an MRI scan where she got claustrophobic, and ultimately a CT angiogram where she could have suffered some side effects of contrast administration, would she be saying the same thing about me? And do we want to discourage physicians from doing that, knowing full well that sometimes they may be right and encouraging the patient to do something they really need, and other times may be wrong? encouraging the patient to do something that may turn out to, in retrospect, have been incorrect.
Right, and so the style of communication is important there, because in a sense, you are communicating to this patient who you did not have hands on. This was a telephone conversation, correct?
That's correct. Although I had as much confidence over the phone as I would have had in person, because with a transient ischemic attack situation, you don't expect to find anything on their exam, and she didn't have anything on her exam. So
right,
but
yeah, you felt I
was not there.
Right, so you felt that the odds of her not being tested were going to endanger her life, and then how you communicated that, the style that you communicated that could be considered either bullying, or it could be just, reflecting the urgency. And this is when we talk about having patients ask, what else could it be? We want the doctors to say, I don't think that this is a life-threatening situation, or I do think this is a life-threatening situation. Yes, it could be something else, but I urge you to do this test because of the concern of the possible case. So that's a style issue, not necessarily a content issue.
But I would also argue this is.
Oh, sorry. Go ahead.
Sorry. Oh, I was just going to say, I mean, ultimately, this is one behavior, and in your example, it came out well, and in the other, it was poor. But there's a sort of that uncomfortable space that we might exist in as the culture of medicine changes, right? I mean, manipulation, whether the outcome is good or bad, is not a great tactic for communicating with patients, either the urgency of the issue or the need for treatment or anything like that. I'm not sure manipulation is the best method, but I also realize that as we are changing, as patients are becoming more engaged and more involved and more willing to speak up and more capable and feel less vulnerable in those situations with physicians, because obviously there's a power differential between a physician and a patient. We might, go ahead.
I apologize. Could I just ask you to flesh that out? And I don't want to make this a one-on-one conversation. I want others to get the chance to get in on the conversation. But you said manipulation isn't a good tactic. I wouldn't necessarily call what I did to her manipulative, but I was basically saying, these are the risks to you. I think they're serious. This is the horrible bad thing that could happen to you if you don't do this. Somebody could view that as manipulative, whether it is or isn't. I was telling her the facts as I saw them. My intent.
But you seem to think it was a little manipulative.
It was a little bit. In other words, she was dismissing the problem. I thought she was underreacting, and I was trying to get her to react more. So yes, I was trying to change her attitude about her own problem by expressing the risks to her. So the question is that, anytime you use the word manipulative, it's going to sound like a bad thing, and it's easy enough to say physicians should never be manipulative. But the question is, forgetting what you call it, manipulative or not, is the idea that a doctor, when a patient is underreacting, goes out of their way to try to convince the patient of something else. Is that fundamentally not a good idea? Or is that fair game in our interactions with patients?
This is Rob Belcara. Oh, sorry. Go ahead.
Go ahead. No, you
go ahead. Well, I was just going to say, I think this really kind of boils down to both physician and patient interpretation of probability and outcomes, and how do people interpret that information. I think that I agree the word manipulation is a little bit tough to interpret, because you could easily call it persuasion as well. And I think that fundamentally the question is, are you saying, like, especially because I think it was paired with deception, I think, in the category, if I got that right. And the question is, are you inherently saying something that you believe is not true just to get a behavior change, or are you just trying, are you using the most maybe dramatic outcome as a way to kind of underscore your point? And I think that the challenge is that if you start saying it's really low probability but high impact, and I think that there's a lot of challenges with the way both clinicians and patients understand and interpret statistics, especially when they're on the lower end. So I think it's difficult to say that the correct way, but I think that's the correct way to communicate that information in a way that would be adequately interpreted. Of course, we see on the other side, as to John Ely's point, we need both sides of this. We see oftentimes with risk management that people come back with a bad outcome, and providers say, well, I let them know about the risks, but you maybe didn't convey the seriousness or the likelihood of the risks. So I think that communication is a challenge in both directions.
I think as a patient, I would like to make a comment. I think that most patients welcome communication from the physician in the sense of diagnostic uncertainty, and the fact that it's not 100% clear what it is, but there's other investigations required which come themselves with risks, but not doing this and not pursuing additional research and additional investigations can pose certain risks, even bigger risks. And I think this type of communication, if it's done in an open manner, I think most patients would welcome it, and rather than trying to pose as being very sure and certain and get stuck on one diagnosis. Maybe I'm biased because that's what happened to me, but I think also before this event, I would have welcomed someone who presents the options. We explore the risks, the probabilities, and then we make some decisions together in partnership, physician and patient.
Dr. Giardina, I have a question somewhat related to feasibility. As some of the discussion has shown, it looks like if patients were to submit narratives, it would involve some bit of 360 evaluation by also asking the clinicians involved in the situation what their perspective was. In your paper, you mentioned that Vanderbilt did implement a system like this for their patient safety or quality monitoring. Do you have any idea, just from a resource standpoint, how intensive was that for them to incorporate that into their safety protocol as we sort of look forward in whether this would be possible for health systems to add to what they're doing?
So I have looked through some of them. I don't know that I can speak to what they're doing as effectively as perhaps sharing some of the literature that they've published, which I'm happy to do. But I think that they have published a few papers sort of talking about how they implemented their systems and how they're working, and data they've been able to collect in different hospital systems that I'm happy to share.
That would be great.
Okay.
I have one other quick question, if no one else does, which is, I was just curious what your thoughts were as far as making these type of systems a bit more inclusive. So obviously these type of systems where patients submit their experiences aren't going to be easily accessible to people who are illiterate or for whom English is a second language, or maybe even people who aren't very tech savvy. Are there methods out there that you're aware of that have been used in those cases for patient reporting to make it a little bit more inclusive and to adapt it to those other populations?
So as far as diagnostic error, not that I know of, but many hospital systems do collect patient complaints And they offer a variety of mechanisms for patients to report any types of issues, which is email, snail mail, regular mail, doing walk-ins, talking directly to a patient advocate, and they also some offer language services so that folks who don't speak English or English is not their first language are able also to report. But those again are for general patient complaints, not necessarily focused on diagnostic errors, but I think that's an important part. And moving forward, as far as patient reporting, I think that is something that I definitely need to consider.
And for the Empowered Patient Coalition, that was all in English and all online?
Correct.
Okay.
We also have a question from Barbara Lewis. She asked, what can patients' families do when confronted with these 4 types of behaviors, e.g. ignoring patient knowledge?
So I think there are some options. Sometimes in hospitals you can ask for a patient advocate. And I also think it's important to have, to always have a family member or someone who can advocate for you along with you. And there's also options of asking to speak to other doctors or requesting a new doctor, speaking direct, like in the hospital setting, speaking directly to the attending. In the outpatient setting, you can identify the advocates in that setting or options to report. There usually are mechanisms to do so. But some of I don't know if there's any patients still online, they might have some suggestions as well.
Hi,
I'm a big fan.
Sorry,
I was just going to say I'm a big fan of get a new doctor. When doctors treat you that way, it's time to move on, find somebody else if it's at all humanly possible.
Yeah, I was wondering about perverse incentives. Like, if, for example, that case about surgery, if the system rewards people for surgery and not reward people for wait and see, how much influence does that cause on the system?
I'm not sure I can answer that question. I apologize.
Hi, it's Holstein again. I just think that a lot of these questions are fabulous questions for the next study because there's a presumption that doctors being open about uncertainty would be well by patients, but we really don't know that for certain. There's been very little studies as far as I know. We would very much like to have doctors be more knowledgeable about surgical risks and medicine risks, and that's an educational component. How do you discuss risk with a patient? What's the best manner? That's another study. I think that dealing with a doctor that you feel is not listening to you, we do say to patients, go for a second opinion. But we have tons of stories that come in of patients that have gone for 3 and 4 opinions and have gotten 4 completely different diagnoses. And what do you do then? A lot of the patients we hear concerns from are people in rural areas where there isn't very many choices. And I just interviewed a woman who was given the wrong diagnosis and then despite her repeated request that if the tissue was healthy when he was doing the hysterectomy, she wanted to keep her ovaries, and he removed them despite the fact that they were healthy. So where do you go with that? Her complaints led to the hospital filing a restraining order. So how's the best way to proceed? I just think that we have a lot of rich questions and a need